everyone. This is Jonathan Sarhadi from MCOL, and I would like to welcome you to our webinar event today, Managing Advanced Illness Through Population Health. Our speaker today is Dr. Randall Krakauer, Vice President, National Medical Director, Aetna. Before we begin, we do have a few housekeeping items to cover. If for any reason you experience technical difficulties with the web portion of today's presentation, please print off the PDF version of the presentation that was included with your dial-in instructions. The link is www.healthwebsummit.com/Aetna091214.pdf. Our speaker will be taking questions today using our live chat feature. So, now and at any time throughout today's webinar, you're welcome to submit your questions. As always, if you require any other assistance, please contact the Healthcare Web Summit office at 209-577-4888. We are now ready for our speaker to begin.
Thank you, and good afternoon or good morning. I'm Randall Krakauer. I'm a National Medical Director for Aetna, and I'm the clinical lead for our care management program in advanced illness that we call Compassionate Care. Starting with the aging demographic, which everyone I believe is familiar with this, and that is that our population is aging, and the mean level of our population is aging, and this is a process that's been going on for quite some time, and it is expected to continue for some time in the future. Now, obviously, the mortality rate for human beings is going to remain at 100% regardless, but this is important in that it does change the number of patients who will die with advanced illness, and that does, in fact, increase substantially with age. Right now, about 83% of all deaths occur in the Medicare population, and the majority of these are dying with an advanced illness that can be identified and increasingly managed. Exactly how this happens varies considerably worldwide and within the United States. Seriously ill patients tend to spend most of their final months at home, but most deaths still occur in a hospital or nursing home, and clearly this does not, based on surveys, this does not represent our true preferences. Our true preferences specified when populations are surveyed or when populations are given informed choice specify that our people would prefer to die at home. This varies tremendously with region. In Portland, Oregon, 35% die in hospitals, whereas in New York City, 70% die in hospitals. And there is no real cultural reason for the bulk of this regional variation. It represents patterns of the way these cases are managed. What we refer to advanced illness is a point in the course of an illness whereby the appropriate approach to therapy, the most appropriate approach to therapy, is supportive. This can vary from individual to individual, can vary with illness to illness, and it's not necessarily a static point. It's a point. It's a point that's part of a progression of illness. But the advanced illnesses represents persons who have one or more conditions that progress through the general health and functioning decline, whereby treatments associated with reversal or substantial amelioration of the basic course of the disease become less effective and, in fact, less appropriate. And supportive therapy becomes more appropriate and more helpful. This is a study that was done some years ago now. It's getting quite old in its initial evaluation, but it's a look at quality indicators in an elderly population and what percentage passed well-established quality indicators. And when studies like this are done, and studies like this have been done subsequent to ACOVE, we frequently find that what we used to call end-of-life care or management of advanced illness tends to fall very low on the list of quality. So, for example, if informed choice, psychosocial support, pain relief, are indicators of quality of life in advanced illness, we are not doing a very good job of it, and at the same time we are generating a great deal of utilization, much of which serves no useful clinical or psychosocial purpose, and in fact is counterproductive. And there are in fact better ways, and most important, the choices do not really represent patient-informed choice. They represent default options which would not be selected had people in fact been given informed choice, and we can in fact demonstrate this. And in that context, it's in fact not only costly, but quite frankly inappropriate. Here are some factors to consider in managing advanced illness and what people tend to desire: freedom from pain, at peace in general, or at peace with God in a spiritual sense, presence of family, be mentally aware, treatment choices followed, finances in order, feel life is meaningful, resolve conflicts, and die at home. Again, number 3, in presence of family. If these are important factors that most patients wish to adhere to, in general, we're not doing as well as we should. Palliative care is appropriately initiated at a point of course in the illness in which we can significantly ameliorate the stress, the anxiety, the pain, and the dysfunction associated with management of advanced illness. It is not the equivalent of hospice. As a matter of fact, the Medicare hospice benefit, as is currently defined, is someone who is expected to die within 6 months, which, by the way, we think should be liberalized, and someone who is willing to abjure, quote, curative therapy. In that context, this would be a late level of support in the course of palliative care. We believe that this type of intervention should be initiated much earlier in the course of a progressive chronic illness or chronic illnesses, to better prepare people for the decision and to be able to provide the kind of support which would be helpful. As I indicated, there is tremendous variation in end-of-life care through the country, and there is also a significant variation within regions and amongst various subpopulations. So, for example, the hospice selection rate in Arizona is over 50%, whereas in New York it's less than 25%. And likewise, length of time spent in hospice varies tremendously. And here we have Ogden, Utah, at 35.5 days, and McAllen, Texas, at 4 days. There is no explanation based on the populations themselves that could reasonably explain this significant variation. The real issue is the availability of the support, which is so helpful to patients and families at this stage of illness. And what we find is, in too many cases, the support that people sometimes desperately need is not provided until very late in the course of the illness. And when I say late, I frequently mean too late, or all too often, not at all. And therefore, we end up with default choices. So the next question is, who is going to provide this support? Well, we have reached the point where now we have palliative care physicians and frequently palliative care teams in at least most of our larger hospitals. But the number of palliative care specialists is still relatively small compared to specialists in general. We have about 1 oncologist for every 141 newly diagnosed cancer patients, and about 1 palliative care specialist for about 1,200 patients with serious or life-threatening illness. The expectation is that all physicians will, to some extent, participate in providing some level of counseling or palliative care, and identify a population amongst their patients that can benefit, and find a source of help for these people, and such sources of help are, in fact, increasingly becoming available. One thing we should say in passing is that palliative care is not, as sometimes portrayed, giving up. As a matter of fact, for an appropriate population with serious or advanced illness, we frequently find just the opposite is the case. And here we are quoting a study of the Institution of Palliative Care for patients with metastatic non-small cell lung cancer. And if these patients were randomly assigned to early palliative care integrated with standard oncologic care or just standard oncologic care alone, and interestingly enough, patients receiving less aggressive care actually lived longer. And in addition to living longer, there was less depression. There was increased mood and improved mood and quality of life, and a better quality of life is measured by physical, functional, emotional, and social well-being. So the experience has been, in general, is that earlier referral to palliative care and or hospice could lead to better symptom management, and in fact usually does lead to better symptom management. So our goals are to align, align the health systems and the people's wishes is to get the right care at the right time, and this is of course true not just for persons with advanced illness, but this is true for all of our patients. Honor patients' dignity, inform and empower patients and caregivers about their condition, provide support, deliver the care in a coordinated manner, and respect and respond to the care needs of those with advanced illness. And that is something in which we can we have opportunity to do better. So with that said, I'm going to discuss our case management program for advanced illness that we call compassionate care. And we've been doing this for almost 10 years now. And at the time we started, it was not in fact clear to us just how effective such an intervention might be. And it became clear very quickly not only how effective it is, but how desperately needed this type of help frequently might be. The goal of the program is to provide additional support to members with advanced illness and to their family and caregivers, and assist them in accessing optimal care, and specifically to promote patient-informed choice. The goal is not to facilitate hospice selection or to encourage hospice election in any way, although hospice can be an appropriate choice when requested by the member. We make no attempt to steer in any one direction, one way or another, and in fact the experience over the last 10 years and the paucity of complaints speaks to the fact that we have not in fact been encouraging any particular choice. The goal is to help a member understand options, and this is done by case managers who are predominantly nurses but also some social workers, and they will assess and manage members' care in a culturally sensitive manner, identify resources to make members as comfortable as possible, particularly addressing pain and other symptoms, coordinate medical care and benefits with community-based services, provide personal support in consultation with the member's physician and staff, including other care coordinators where available. So the goal is to provide a needed level of support and assistance with decision making. A case plan is developed based on the initial assessment and discussion of goals with the patient facilitated with the family and the physician. Frequently we address issues such as pain and symptom control, and we identify social service or other needs and facilitate them. This case plan is done in consultation with a medical director with experience in this field and in integration with other clinical programs. The case manager remains in touch with the patient, with the family, with the physician and staff, as long as this assistance is deemed helpful. We do not discontinue service when a member elects a hospice, for example, but only when we feel that reasonable goals have been achieved, and that our assistance is no longer necessary. And frequently, we continue with the case until the patient dies. Examples of barriers to effective care, which we frequently see, are inadequate treatment of pain and symptoms, lack of knowledge of care options, lack of emotional support, late referral or frequently no referral, and difficulties in determining the prognosis. And determining the prognosis in advanced illness can, in fact, be difficult. But as I indicated, one of our issues is that we so frequently see that referrals for palliative care or case management are made late or too late, or all too frequently not at all. And this type of help, which is often desperately needed, frequently is not available or not available in an optimal way. The case manager has a considerable amount of training and experience, and in fact, at this point, we have a cadre of case managers with years of experience in this area and very good results. They work with patients and families on advance directives and living will information and assure access and understanding of the material. They work on pain and symptom management, and most importantly, facilitate informed decision-making. They will discuss choices and options with a member and family, review that make sure they understand as best as possible what their prognosis might be, address their concerns, and plan how to spend their time as options become limited, and address spiritual and cultural needs as appropriate. And all of our case managers have had training in case management. They've all had clinical experience. They've had training in case management, in change management, in advanced illness, and in cultural sensitivity. Most of them have, at this point, have had significant experience in this field, and sometimes years of experience. They will facilitate informed decision-making, assist with provider access, and enable members to have their changing needs met, educate them on benefits and choices, explain palliative care and hospice as an option and what is available to them, and we'll discuss with them and make available to them various sources of information, including of our own website. Members are identified in several ways. In terms of our Medicare Advantage population, the majority are actually identified by a claims-based proprietary algorithm. A number of them are identified through the regular case management process as we identify cases with chronic illnesses and other illnesses that are appropriate, and occasionally through concurrent review or pre-certification for example, of inpatients. We also get referrals from physicians' offices, particularly those with embedded Aetna case managers in provider collaboration practices, and we get direct member and patient referrals that are calling for information, resources, or benefits questions. The program is not designed around any particular diagnosis or set of diagnosis, but rather the stage of illness as defined by, as I previously indicated, an illness that has progressed to the point where the term advanced illness becomes appropriate. We address the patient's needs and look for opportunities to improve their adjustment to their condition and make appropriate choices. Some of our case managers are social workers, and they can be very important. And it does come to pass frequently that psychosocial issues can dominate the needs associated with a case. And social workers can help with the member assessment and also can help with access to community resources, state and federal resources, and other community and other levels of community support that may be available. Common issues include in-home support, home-delivered meals, financial and transportation needs, and food and service needs. The case manager follows the member as long as they can be helpful or as long as desired by the patients and family. They maintain close collaboration and try and keep coordination between the member, the family, the caregiver, the physician staff, and other physicians that may be involved in community services to try and maintain a continuity care and try and maintain as coordinated possible level of support provided to the patient and family. They will provide ongoing support to the caregivers and, in fact, provide valuable advice and assistance from people that are familiar with the process to caregivers who may not be familiar with the process. We find training is integral to the success of the program. I have seen programs that have not been successful and that have not shown impact. And when these programs are evaluated, what we frequently find is that this has been the point of disconnect. I have been asked what is the secret sauce here, and my answer is there is no secret. Everything that one needs to know to implement this program has been published and is available from public sources. That doesn't mean it's easy, and that is selecting, training, and mentoring people who can do this is hard. We frequently find that that nurses with clinical experience tell us that they are uncomfortable initiating this conversation. And in fact, this can be a sore point. And not every potential case manager can in fact do this. And we find that when they can't, we usually don't have to drop them out. They usually drop themselves out. But I can tell you that now that we've been doing this for years, that we end up with a cadre of case managers who are nurses and social workers who are extremely good at this, extremely effective at this, and who find this rewarding and feel that they are accomplishing something very useful. And this is what makes it work. These are people with clinical experience, with additional training and additional mentoring. And at this point, we have a number of case management supervisors who can mentor new people very well. Our case managers don't do just advanced illness. And as a matter of fact, in Medicare, although they frequently handle advanced illness, they handle the full spectrum of members who need case management. On the commercial side, advanced illness is less common and a less common intervention. But for those that they do, it's equally important. Nonetheless, as I indicated, 83% of all deaths are in the Medicare age population, and an even larger portion have identifiable advanced illness. Case managers who have existing cases can identify members that are appropriate for the program, although we identify the majority through algorithm. But the case manager's job basically is to support patients in need of help through all phases of their lives. So in that context, advanced illness is an integral part of each case manager's skills. I've been asked for information on satisfaction, and what I can tell you is the satisfaction with this program is considerable. As a matter of fact, you would almost have to say that satisfaction is not even the appropriate word. Gratitude is a more appropriate word. And we have, over the course of years, developed a huge amount of feedback and letters, phone calls, etc., that are highly gratifying. And after many thousands of individual transactions, not one single member complaint, which is really rather remarkable because, truthfully, there is nothing you can do this often without generating member complaints. And the paucity of member complaints speaks to some degree to how much this type of program is helpful and how much this type of program is needed. And truthfully, the absence of the level of risk or, quote, blowback, close quote, that some tend to fear. So out of all of these types of communications, I have just selected one as an example. And this is actually a case manager's closing note, which I think illustrates so much of what I've been trying to say here. And I think it's most effective when I actually read this note. Wife stated member passed away with hospice. Much emotional support given to spouse. She talked about what a wonderful life they had together, their children, all the people's lives that he touched. They were married 49 years last Thursday, and each year he would give her a piece of jewelry. On Tuesday, when she walked into his room, he had a gifting card laying on his chest, a beautiful ring that he had their daughter purchase. She was happy he gave it to her on Tuesday. On Thursday, he was not alert. She stated that through his business he touched many people's lives, and they all somehow knew he was sick, and he received many flowers, meals, fruit, cakes. She said her lawn had become overgrown, and the landscaper came and cleaned up the entire property, planted over 50 mums, placed corn stalks and pumpkins all around. She said she is so grateful for the outpouring of love. Also stated that hospice was wonderful, as well as everyone at the doctor's office and everyone here at Aetna. Encourage her to call case manager with issues or concerns, closed to case management. Now, the reason I read this to you is because, well, first of all, it has a greater impact when I read it than when I ask you to read it, but mostly because you can feel the depth of the connection in this note between this case manager and this member's spouse. And it is that depth of connection that makes this program work, and frankly, what makes case management in general work. Without that connection, this will not be effective and you will not see impact. And when I look at programs in which we do not see impact, that's usually what I believe is the problem. So when I say that everything you need to initiate this program has been published, I mean that. But that, like I said, that doesn't make it easy. Selecting, training, and mentoring a population of case managers who can do this is hard. And what we find is, if you do not carefully select your case managers, if you try and give them training on just exclusively online or through a manual, if you try and script the conversations, you will end up with a program that is less costly to implement, but also ineffective. And we have, in fact, seen that happen. And that's my comments from this particular note, and what I'm trying to illustrate with this one single note out of literally thousands. So what have we seen with this program? Well, we get an 82%, in terms of our Medicare Advantage population, we engage approximately 1% of our entire Medicare Advantage population annually in this program, in compassionate care. Of those in this program, 82% elect hospice, not because we steer them to hospice, but because this is, in fact, what they elect when they are given informed choice, which is considerably higher than the election rate for an unmanaged population. And the election rate for unmanaged population varies considerably. Now, the Robert Wood Johnson Foundation and others have done surveys of populations, and when asked the question, given that you have an advanced illness, and they will define advanced illness, and given these choices, what would you choose? What option would you choose? Consistently, about 75 to 80% say they would elect hospice. So when we're seeing election rates that are well below that, that is evidence that people are not being given informed choice. They're ending up with default choices. And that when we're seeing an 82% hospice selection rate, what that basically means is we are realizing what constitutes, in fact, patient-informed choice. This is associated with an 82% reduction in acute inpatient days, a 77% reduction in emergency room visits, and an 86% reduction in intensive care days. Now, I have been a medical director for some years now, and I never get to say 82% reduction. That is truly a remarkable impact, isn't it? That speaks to me to two things. Number one, we have a great program. Of course, that goes without saying, but more importantly, we're providing a service that is so often desperately needed and so often simply not provided. And the fact that we're working in what essentially is virgin territory in so many cases is the reason that we're seeing an impact of this magnitude. Another observation is, if you see an impact of this magnitude, doesn't that create an imperative that this type of service be made available? That if we are not in fact facilitating patient-informed choice that we should be, as an example, let's say that we had an illness in which we came up with a drug, and this drug produced an 82% remission in was otherwise a serious illness, how long would it take once this was established and published before this drug became standard of care? That being the case, shouldn't this type of provision of this type of care management or support, which could be provided in many different forms, by now be standard of care? And what will it take to make it standard of care? We have several publications of our own on this, and we'd be happy to share them. This one's in Journal of Palliative Medicine, in Health Affairs. We presented this in various meetings, and we'd be happy to share any of these publications with you if you request them. And others have had similar experiences. So, for example, the AIM program at Sutter Health, Johns Hopkins, the Gunderson Clinic, and others have instituted programs of palliative care and support in various ways, in various manners, but the one common thread being they provide expert assistance by experienced personnel to people with advanced illness, and they get results like this. So once again, this speaks to the need that this type of support becomes standard of care. We provide it to our members in the form of case management. That's not the only way to do it, but I think it's important that it be done. So, in summary, improving the quality of care for those with advanced illness represents a tremendous opportunity for the country's health system, for patients, and for their families. So I'm going to say that, particularly in terms of the Medicare population, if you're looking for the potential for impact at the intersection of quality and cost, this is the mother lode. Now, in fact, for years, when asked how much it saves, I had to answer, I can't tell you. I can show you the reduction in acute care, but I can't give you a dollar figure. Well, now we have in fact released and published the dollar figure, and we're saving $12,600 per engaged member in our Medicare Advantage program. That being the case, that I will say once again, if you're looking for a potential for impact at the intersection of quality and cost, this is a huge untapped opportunity. It requires a coordinated, holistic, and patient-centered approach. Programs such as ours can increase the awareness of care options available, aligning patient choice with the health services available, and they can favorably impact the outcomes with advanced illness and produce very high rates of satisfaction and dramatic impact on cost and quality. And we believe that fact, which I believe has been well demonstrated by ourselves and others, creates an imperative that such services become more widely available. Thank you very much. I am now prepared to take questions, and it looks like I have a series of questions. The first is, presenter is difficult to hear, voice is soft. I'm sorry about that. I should have seen this earlier in the course. The voice level was checked before I started, so my apologies if that's been a problem. Understanding that the claims-based algorithm used to identify patients, can you share what elements are... the claims-based algorithm is proprietary. You can almost guess what it is. We're looking at claims and we're looking at transactions. So obviously we're going to look at certain diagnoses. We're going to look at hospital inpatient stays and the diagnoses associated with that stay. We're going to look at comorbidities. We're going to look at use of certain drugs. We're going to look at ER visits. We're going to look at a wide variety of claims and information associated with these claims. And we're going to look, and this was originally developed almost 10 years ago, and there have been several iterations since then. And basically what we do is we look at decedents, and then we look at claims prior, up to 12 months prior to death, and we look at types of claims and combinations of pieces of claims that are associated with dying within 12 months, and we identify what can be used for predictive modeling. we still have to validate it. I mean, once we identify a patient or a member with advanced illness, we still have to validate it. Now, it's not like we're identifying people with basal cell carcinoma or anything like that. But nonetheless, you can still get, no matter how careful you are, you can get false positives. So it still requires a clinical validation. We're not the only predictive modeling algorithm that's out there. There are other algorithms out there. But if you're interested in having a discussion about this, let us know. Here's another question: Are your team members RNs, SWs only? Yeah, well, they are RNs and SWs. There are some APNs. There are some psychologists, but they're predominantly RNs. Is the RN the primary contact for patients? What is the caseload array? Okay. The RN, the caseload tends to vary. A case manager's caseload can be anywhere from 40 or so to 55 or 60, but it depends a little bit on the distribution of cases. And if you're looking exclusively at advanced illness cases, your caseloads would be somewhat smaller. Approximately how many times will a team member meet with the patient? That varies considerably. And is it telephonic or in person? The overwhelming bulk of our contact is telephonic. And this kind of speaks, interestingly, it speaks to the potential for telephonic contact. As imperfect as a telephone is as a means of communication, isn't it remarkable the kind of impact we get by telephonic contact? We do have case managers increasingly embedded in physicians' offices, and we are looking to increase the numbers that are embedded in physicians' offices, and we're looking increasingly to case management home visits also. Do you bill patients for these services to Medicare? Now, this is part of a Medicare Advantage program. So these case management services are provided as our care management component of our Medicare Advantage program, and they are not billed. They are not billed to Medicare. And this question may have been triggered by the CMS plans or potential plans to pay for care management services, but this is not associated with that. We've been doing this for 10 years. How is ACC book coordinated with palliative care teams in physicians' offices and hospitals? We work very hard to coordinate with the physician's office and where a palliative care team exists with the palliative care team. In many times, palliative care physicians or teams are not available. When they are available, we will work with them, and frequently what we find is that they're available predominantly for inpatients and not for outpatients, in which case we will try and coordinate services with the, and provide the bulk of the support for outpatients. In places where outpatient palliative care is available for a particular member, we will work with the palliative care team, and we frequently find that we become a source of care management coordination between the palliative care team, the primary care physician, the specialist, and others. Increasingly, we are looking to become part of comprehensive palliative care programs within a community, and we're establishing some pilots in several communities around the country in which we're going to collaborate between our case managers, palliative care teams in hospitals, and home visit teams to try and create a continuity in which all of our efforts are coordinated, and to some extent the glue that's holding the pieces together are our telephonic case managers. Training session, okay, there's two. What type of medical education do you provide, or the person said? Okay, we hold training. We have in-person training. We have web-based training. We have telephonic training. And we have mentoring. We have a little bit of everything to answer what type of continuing education or training do you provide. In terms of medical education, we have a case management program which can be delivered in most parts of the country by Aetna medical directors. We have a grand rounds deck which we have used to present medical grand rounds by invitation at a number of hospitals throughout the country. So if you're interested in a grand rounds presentation at your hospital, for example, or some other type of such presentation, let us know, and if we have trained medical directors in your territory, we will try and accommodate you. Have you published the dollar amount saved per member? Yes, we have. We have in fact done so. This was for years we didn't even calculate the number. Then we calculated the number because we were requested to by CMS. I think it was about 6 months ago. We published the number in the Wall Street Journal. So I guess once you publish the number in a newspaper with a circulation of 2.5 million, you really can't claim it's a secret anymore, can you? So the number that number has been published in the peer-reviewed medical journal called the Wall Street Journal. Do you provide 24/7 access to these services? We don't, not everywhere. In some form or another, we're trying to do that. What is the ratio of case manager social? I think I did that. I answered that one already. What is the communication process to inform the enrolled patient's PCP of the patient's treatment preferences? We try and coordinate with the physician, and most particularly the primary care physician, as well as possible in any way possible. The means of communication is the telephone in most cases. Increasingly, we have case managers embedded in physicians' offices who will develop a relationship with the physician and the staff, and that is certainly our preferred way of doing things. And we're looking to a point where at least half of our members are covered by provider collaboration arrangements with embedded case managers, but we're not quite there yet. So right now, the majority of this is still telephonic. We will reach out to the physician's office, and most particularly the primary care physician's office. We will try and speak to the physician when possible, to the physician's staff when that's not possible. We will take callbacks from the physician since they're frequently busy when we call them, but we will do our very best to coordinate with the physician's office and their staff. And we consider that type of coordination extremely important. And what we find is that in most cases we are in fact successful to one level or another, and in most cases the physicians, the physicians really do appreciate our help, and we really do provide a substantial amount of help to the physicians who have members of ours with advanced illness. I told you that many thousands of cases we haven't had a single member complaint. In fact, we've had the number of physician complaints we've had about this program over all these years is in the single digits. Can you describe the training? We have, in terms of continuing training, we distribute information through email. The question is talk about ongoing training and education of your staff. We can distribute information by email. We have WebExes like this one, for example. We will provide web-based training. There are rounds with medical directors that are frequently held, and in fact, our staff holds training sessions with our medical directors. So we just held the last session we had with our medical directors was I think 2 or 3 months ago, and we have another one to schedule very shortly. So we have various means of training, and we have online training and web-based training also. Looks like I've reached the end of the questions in the chat box, I believe. Are you training your staff specifically on how to elicit the patient's wishes? Yes, in fact, we are. That's part of the training in change management. We are trying to facilitate patient-informed choice. Actually, if you'll send me your email address, I will send you a publication we have on this in particular, and that is, what is patient-informed choice? How do you elicit it? Is it stable over time? How do you best facilitate it? And we recently published a piece on this in the Journal of Clinical Ethics, which I would be happy to share with you. I have your name. I don't know if I have your email address, but if I can get it, I will send that to you. If there are no other questions, Okay. Okay, I just got the email address. So if I will send that to you. Thank you very much, folks.
We would like to take this opportunity to thank our speakers and session participants for joining us today. We will be sending a follow-up feedback form at the conclusion of this event and would love to receive any feedback you wish to share. If you haven't already done so, please be sure to join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.